this short video, we will talk about restrictive lung disorders. So restrictive lung disorders are exactly what that is. The lung is restricted. So there's an inability for the chest wall and the diaphragm to move with respiration. And some of those disorders include pleural effusion, empyema, and atelectasis. When we have a pleural effusion, there's a fluid buildup in the pleural space. This is often confused with pulmonary edema. So we want to make sure that you know the difference between the two, and we'll talk about pulmonary edema in a different video, but for pleural effusion, the fluid is in the pleural space. And as you can see, the fluid is filling up in that pleural space, shrinking down the area that the lung can expand. So again, it's restricting the lung. So if the lung is restricted, you're going to have decreased perfusion. You're not going to be able to take a deep breath. When you're listening to the lung sounds in the area where the pleural effusion is, you're going to have decreased lung sounds. You may have absent lung sounds, and sometimes you may hear wheezing as well as crackles. When we have an empyema, it's basically the same thing is occurring. There is fluid in the pleural space, but this is pus-like fluid. So typically there's an infection going on. You'll have the same signs and symptoms, except now with empyema, the patient will also have signs and symptoms of infection. So this chart here kind of breaks down the differences for those different disorders for you, kind of breaking down what might be the cause, what might be some of the signs and symptoms, and how you would diagnose and treat that. So when we look at the pleural effusion, again, fluid in the pleural space, these are not going to show up until you have more than 250 mLs of fluid in that pleural space. So that's quite a bit before you can actually see it on the chest x-ray. But for pleural effusion, the most common cause is going to be heart failure. Other things, pneumonia, infection, pancreatitis, some of those things can also be causes, but your main cause will be heart failure. You're going to have shortness of breath. Because of that decreased chest wall movement, you're going to see, like I said, the absent or decreased breath sounds. With the empyema, a lot of times it's caused by some other type of infection. So maybe pneumonia, tuberculosis, you can see with lung abscess, lung cancer, any type of infected chest wound, let's say a stabbing, an infection post chest tube, anything like that. So the signs and symptoms, like I had said, will be the same, but now you're going to have some signs and symptoms of infection. Fever, night sweats, cough, maybe even weight loss. When we're looking at diagnosing these two problems, we can see it on a chest x-ray. A CT scan would also give us an information. It would be a little bit more in-depth information. And you might have a thoracentesis. So the thoracentesis can also be used for treatment as well. So it will be diagnostic. It will tell us if there is bacteria in the fluid, if there are any cancer cells. But once we know what the problem is, we can also remove the fluid, and that will be what makes it treatment. So if we remove that fluid from there, the signs and symptoms that the patient has will resolve. Now, of course, if it's an empyema and it's infectious fluid, then they would need to be treated with antibiotics. Both patients might need oxygen, depending on how well the other lung is compensating for them. Another restrictive disorder is atelectasis, and that's obstruction of the small airways with secretion. And so a lot of times we get atelectasis if someone has pneumonia, if someone is bedridden. Post-op patients have increased risk for atelectasis, and that's why coughing and deep breathing is extremely important. Someone with atelectasis can have decreased breath sounds, dyspnea, crackles, even absent breath sounds. And the treatment will be to treat the cause. So if we know it's pneumonia, we're going to treat the pneumonia. But coughing and deep breathing can help resolve this problem, but also can help prevent it. So mobility, so our bedridden patients, if we can get them moving, post-op patients, as soon as we can get them ambulating, that's also very helpful. And then oxygen. So they may need oxygen as well. It will, again, depend on how the patient, the rest of the lung or the other lung is compensating when we look at their pulse ox and their oxygenation status. Briefly, I mentioned thoracentesis, and so like I set up a procedure for either diagnostic treatment or treatment, and you can see that we're removing fluid from the pleural space. So a lot of times this can be done at the bedside, In more complicated cases, it would be done in like a radiology department, under fluoroscopy, maybe even in the OR, depending on your site. But basically, if the patient is stable and it's not very complicated, the patient can sit up at the side of the bed or on an exam table. They typically lean over the bedside table, and under sterile conditions, a needle will be placed into the pleural space by a radiologist, a physician assistant, maybe even an NP, and they will drain the fluid from that site. So your job as the nurse, a lot of times, is really just to make sure the patient is comfortable during this procedure, and then assessing them afterwards for any complications, making sure their oxygenation status is better. And typically when they remove the fluid, you will see the patient's status will improve. Also, you saw in here, we usually remove about 1 liter at a time, and that really is because if you remove too much fluid, it can cause electrolyte imbalances. It can also cause fluid balance shifts, so you'd be looking for hypovolemic signs and symptoms if they would remove more than that during thoracentesis. So that concludes this